Well, good afternoon, everyone. Thank you so much for coming and joining us today at our National Neonatal POCUS Collaborative webinar. My name is Michael Janesco, and I'll be your moderator today. So just before we start, just wanted to let everybody know of a few general housekeeping items. If you've been a regular guest at our webinars, you probably already know this, but just for those who don't, just a couple things to make note of. The chat is disabled for the audience. But the moderators will sometimes send out general announcements via the chat. For those, if you have questions, which we certainly highly encourage, you can use the Q&A feature to post the questions, and those will be collected by Karina and some of the other folks, and they will collate them and put them together, and they will be answered during the Q&A panel session. And of course, this webinar is being recorded and will be uploaded to the collaborative website, which is NeoPocusCollab.com, but that's all over the slides and everything, so you should not have any problems there. So without further delay, let's proceed to our main talk. Today's the second webinar in our Spring Cardiac POCUS series, and we will continue to explore cardiac POCUS uses in neonatology. Our guest speaker today is Dr. Shazia Bhombal. Dr. Bhombal is a dual-trained board-certified physician in both neonatal perinatal medicine and pediatric cardiology. She has extensive clinical and research interests in neonatal hypodynamics, as well as utilizing ultrasound in the neonatal intensive care unit. She is an associate professor of pediatrics at Emory University, the vice chair of the National Neonatal POCUS Collaborative, and a member of the Targeted Neonatal Echocardiography Special Interest Group within the American Society of Echocardiography. So, Dr. Bhombal, whenever you're ready, please take it away.
Okay, sorry about that. My screen froze for a second. Okay, thank you so much for that introduction. I'm very happy to talk to you all today about neonatal cardiac POCUS, indications, limitations. Can you see my screen okay? Great. All right, I have no conflicts of interest to declare. Learning objectives, we're going to identify when to utilize ultrasound for cardiac assessment by POCUS, describe standard views of cardiac POCUS used in neonates, and recognize the limitations of bedside POCUS for cardiac assessment. So just a couple clinical cases here. You see a full-term infant that's presenting with omphalitis, goes to the OR, development of necrotizing fasciitis, gives multiple boluses due to hypotension, said, well, do we need more fluids, more pressor support? What's going on with this baby? And bedside ultrasound is a subcostal view. This is left ventricle in here. It doesn't look like it's moving very well. So it gives you a little bit information on what could maybe help this patient. You can use it for real-time assessment during resuscitation. These are two different cases that occur during resuscitation. This is one where a baby was coding, and as they're doing chest compressions, went in, did some ultrasounds to try to assess if there's any etiology that we could immediately enact with. And so this demonstrates a subcostal view. This is left ventricle here, not moving very well. And this is a different patient, a very large pericardial effusion. So having imaging, being able to look at the heart can give you some more information that may help you to triage patients faster and get them to their treatment. Now, more advanced, thinking about our ECMO patients. This is a patient on VV ECMO. And this is the cannula. It's in the right atrium in here, in a reasonable position based on echo. It looks a little bit deep here, and you can see these very well by ultrasound compared by X-ray, and was actually very deep by X-ray as well. And this one, unfortunately, did develop a big pericardial effusion. So by looking at these cannula positions, be able to adjust in real time, can we avoid some of our complications? So can using POCUS really help us in management of these patient population? So there are many different names for cardiac ultrasound. We're going to go over a couple of different considerations when you're thinking about point of care ultrasound and these are neonates. So with increasing training, you can start with point-of-care cardiac ultrasound. We've heard a lot in the Patrick talk last month about targeted neonatal echocardiography, and then also other comprehensive echocardiography with looking for congenital heart disease. And really, there's increasing training for each of these. But really, the benefits of cardiac ultrasound is you have a specific question that you're trying to ask. It is time sensitive. You're at the bedside trying to understand a baby's decompensating. Is there cardiac pericardial effusion leading to cardiac tamponade that's affecting your physiology? It's a limited evaluation. It helps to refine your differential and does help you to guide management. And when you're thinking about three elements that can govern the use of cardiac POCUS, you want to know, is the assessed structure amenable to ultrasound technology? So can you put a probe on and get information because ultrasound beams can address this? Does the identified physiology and subsequent management decisions, are they frequently encountered in the clinical care setting, or is a condition required urgent or emergent assessment, such as a pericardial effusion, to guide potentially life-sustaining management? And finally, can pediatric non-cardiology clinicians reliably assess the physiology of the bedside following dedicated education and supervised training? And there's really a lot of literature, a lot of information. We've gone over this, is that it started off really in the ER as far as bedside clinicians trying to utilize ultrasound to triage and to address patients faster. So this was a study done in 1992 when emergency department looked at patients who came in who were able to have echo versus those that were not in having penetrating cardiac injury. And really what they found is that patients with a penetrating trauma who had immediate ultrasound evaluation had 100% survival with time to diagnosis and surgical plan of about 15 and a half minutes for cardiac ultrasound compared to 42 minutes for the non-echo group. And you could see on the left, predicted survival when they used their metrics was about 32%. With no echo, they had about 7% survival, and 34% in the echo group and 100% survival in that group. And again, the time for triaging, what really seems to potentially make a difference, much faster when you can put a probe on when a patient comes in and be able to triage these kids faster and get into their treatment. Similarly, there's another study out of the ER that showed emergency echocardiography developed to detect pericardial effusion in patients with PEA and near PEA states. These were tiny patients with came to the emergency room for non-traumatic hemodynamic collapse, and they looked at PEA or near PEA states, and they were able to look at cardiac motion. If they did have cardiac motion, was there a pericardial effusion present? And that was able to be intervened on those patients. Many of them did end up surviving. 3 of these patients had tamponade that had emergency pericardial drainage surgery. Again, emphasizing the rapidity to triage. We're not trying to diagnose congenital heart disease. We're not trying to diagnose major pathologies other than ones that we can potentially triage and treat faster. So from a neonatal standpoint, bedside ultrasound has really evolved over the past few decades. And again, initially it's reported as a tool for evaluation of abdominal trauma in the 1970s. The neonatal world, the Australian neonatologists, were very early adopters of cardiac ultrasound in the NICU in the 90s. And then subsequently we had targeted neonatal echo guidelines in 2011. But more and more is recognized that we needed to be able to put the probe on these patients and triage, get these patients to their management therapies quicker. So the recurrent theme for the recommendation of the guidelines over the years highlight there's an important role for cardiac POCUS. And again, most recently, which we'll go over, are the Journal of American Society of Echocardiography, targeted echo, and cardiac POCUS recommendations that were just published this past year in 2024. Remember that cardiac POCUS is a problem-oriented, physiology-based imaging tool performed by non-cardiology clinicians to complement other clinical data elements and enhance patient management. And this has really been reviewed and discussed and collaborated with by the American Society of Echocardiography. From a cardiology standpoint, this was early on, this is in 2010. ACE recognized the utility of bedside cardiac POCUS and partnered with the American College of Emergency Physicians to publish a consensus statement. It really outlined the goals of a focused cardiac exam in symptomatic emergency department patients. And these included assessment for presence of a pericardial effusion, assessment of global cardiac systolic function, identification of marked right ventricle and left ventricle enlargement, intravascular volume assessment, pericardiocentesis guidance, and then confirmation of transvenous pacing wire placement. And while this was very much utilized in the ED, we recognized more and more that in pediatrics and neonatology, we were wanting to use POCUS as well, and there was some utility in that. And so this paper, very important paper on many of the authors are on the panel are participating today in 2020, was an international evidence-based guidelines for point-of-care ultrasound for critically ill neonates and children. That was out of ESMIC, the European group. That did also include US, many of the leaders from CHOP that were on this paper as well. And in this paper, it discussed that the goal of cardiac POCUS was to obtain physiologic and hemodynamic information to aid in clinical decision-making. But again, and I'll hone this throughout the presentation, if there are any structural abnormalities suspected or diagnosed, this is not a tool that is to be used as a screening tool for congenital heart defects, and really any concern for congenital heart disease and a formal echo with full congenital heart evaluation should be done, really should be done in all of our neonates that don't necessarily have proof of life. And then finally, the document that came out was such an important for us very recently, past couple of years, the use of point-of-care ultrasound in the NICU for diagnostic and procedural purposes. And this was really landmark for us because the AAP deemed that POCUS is necessary. There is utilization and need for in the NICU. And so this really helped us to have the credibility and the guidance to be able to put together and put out guidelines and development for POCUS programs within the US. And in this, there did talk about cardiac POCUS, and so another realm where cardiac POCUS is deemed to be important. Again, in 2023, the ACE again published cardiac point-of-care ultrasound specifically for pediatrics. This one looked at preload and volume responsiveness, qualitative LV systolic function, pericardial fluid assessment, and qualitative assessment of RV size and systolic pressures. So again, recognizing that there is utility, there's importance of being able to look, and this is with the guidance and with the collaboration of the Society of Echocardiography. Now, what was really pointed out in this is that this guideline really only applied to the pediatric population. It did talk about neonates that may present to other units, such as in the ED, and have a first exam, but excluded targeted neonatal echocardiography. And so with that, there was always a desire to have an update for these targeted neonatal echo guidelines that were published in 2011 that Patrick talked quite a bit about the last time around. And so with these guidelines, with the update to the guidelines, one of the important things about the guidelines for the TNE update was that cardiac point-of-care ultrasound was really emphasized and added, recognizing that many people want to be able to put the probe on to be able to assess for clinical deterioration and something that we can, again, intervene on, pericardial effusion, the heart not moving, moving or not. And so giving some guidance on separating out targeted echo, which does more evaluation and hemodynamics, and really be able to do cardiac POCUS. We can teach many people how to take good looks at the heart. And so this statement outlined that neonatal cardiac POCUS is a limited cardiovascular evaluation that may include line tip identification, identification of pericardial effusion, and differentiate hypovolemia from severe impairment in myocardial contractility in the hemodynamically unstable neonate. So again, looking at these different things, central line tip position, is the heart moving or not? Do you see pericardial effusion? And do you have suspected hypovolemia? What are things that we can act on rapidly in certain situations? Now, this talk isn't quite long enough to go over all the views for cardiac POCUS, but we generally are looking at a few main views. So parasternal long and short axis views, looking at subcostal views, and apical four-chamber. You'll notice that from a neonatal standpoint, the PDA is not included in this view and suprasternal notch. There is some valuable information to be obtained from that, but that may take more training. And from basic indications, we're not necessarily utilizing that as a basic application for cardiac POCUS in the neonates. So to go over a couple of different areas and a couple of the different recommendations. So central tip catheter tip location. So we've all been in situations like this. A newborn undergoes a UVC placement. The line is placed, they're waiting for an X-ray. The line is in the liver. You manipulate further and wait further for an X-ray. The line still needs adjusting, another X-ray for final confirmation. And finally, 2 hours later, that line is actually in. And I'm sure many of us have been in this situation, and particularly when you think about resource utilization in places where you can't get an X-ray quicker, then be able to have the ability to look at lines, assess whether they're above the diaphragm. We can put the top down, maybe get to golden hour faster. This could be a big difference in what we can do for our patient population. And so UVC tip position, looking at by X-rays a tip position low and confirming that left UVC that's pretty low in the ductus venosus area, a UVC that's more in the right atrium. Is it heading towards the atrial septum? And this one where you actually do have a high UVC that you can see that goes into the right atrium, and we do sometimes you can do, or into left atrium, towards left atrium, and you actually flush that line and potentially see some fluid going into the left atrium. And that may give you some indication that pulling line back is going to be beneficial for this patient. And so we can get a very nice view by ultrasound compared to X-ray. I always find it amazing when you think about, when you really look at the imaging and where these lines need to go, thinking here's the umbilical vein with the umbilical recess sitting in here. Left portal vein goes in this way, so we see our lines can sometimes go in many different areas, and then getting through the ductus venosus and getting to the RA. So could be challenging to get those in. And with ultrasound, we can actually direct see how this line goes in. This is the umbilical recess in here. Here's a line traversing the ductus venosus and heading into the RA. And Ben Koziak has some really nice talks and has discussed how the use of real-time ultrasound guidance for UVC cannulation in neonates, looking at a congenital heart disease population, but there are others that are doing this on neonates without congenital heart disease. And you think about how we try to manipulate the liver when we're putting in the UV lines. You can really direct it with guidance by actually straightening things out with utilizing ultrasound. So there are definitely uses for being able to look at lines and line position with cardiac POCUS. Looking at qualitative LV systolic function, what's so important when you're thinking about cardiac POCUS is understand that the more normal you see, the more you recognize when something doesn't look right. And I say that's really important because when you're talking about how long does it take to be able to get competency, that is a structure that we're working on. We have the committees that are working on this, try to get some more feedback and understanding on where our competency is as far as how many ultrasounds. But the more that you recognize normal, the more you recognize when something isn't right. So this is a parasternal long axis view where you see the right ventricle is up here. Here's a left ventricle here. Aortic valve, about a rule of thirds, right ventricle, aortic valve, LA. And in this view on the right, you have a dilated LV decreased function. You can see it just doesn't move that well. And you start recognizing when something looks right. When you put a probe on, you're trying to differentiate this child is hypotensive, we're giving volume, it doesn't seem to be making a difference, or the baby's getting worse. Putting a program can help you differentiate. Now, we can't tell if there potentially is underlying congenital heart disease that could be impacting this. So it is important also to recognize that by putting a probe on a baby who has not had a full echo, recognizing abnormal means, again, you can triage faster and have pediatric cardiology or have hemodynamics, have someone be able to come and do an echo that's more a comprehensive echo to look for congenital heart disease. And again, looking at another view, this is the subcostal view, where you have liver is here, is inverted. In the cases where you are doing a quick exam, subcostal, when you're doing in a code situation, you can look to see, is the heart moving? These are examples of heart is not moving well. Again, LV here, compared to a more normal left ventricular function, heart is squeezing. And you can also look for pericardial effusion, big black ball around the heart. None of that you see here, but the more that we recognize normal, the more you'll recognize when things are not normal. And then pericardial fluid assessment. So when you're looking at for example, here's a parasternal long axis view. So looking at the parasternal long axis view, again, you have the right ventricle on top. That's the first structure your ultrasound is going to hit as the RV wraps around the LV. RV's on top, your aortic valve in middle, left atrium is behind. If you can identify the descending aorta, then the space between the heart and the descending aorta is a pericardial effusion, and posterior to that is a pleural effusion. So in this patient, we actually have both. Here's a pericardial effusion. Don't see a great view of the descending aorta in here, but a pericardial effusion separated off from a pleural effusion. And here, so trying to differentiate, you see, trying to recognize a pericardial effusion. Here's another example of a pericardial effusion, but also poor function. Again, the more normal you see, the more you recognize an acute situation when something is abnormal. So here's the right ventricle, thick, not moving very well. Left ventricle is not squeezing well, or is rather fairly underfilled. And you can see black around the heart. Here's some pericardial effusion. Here's your descending aorta, pericardial effusion in here. Another view, here's a peristernal short axis view. Again, normal peristernal short axis. So you're now see your left ventricle on the bottom here, nice and rounded. Right ventricle on top, crescentic sitting around the left ventricle. Again, the ventricles now are not moving too well, and you see a lot of fluid. It's black fluid around the heart, indicating consistent with a pericardial effusion. And looking at these from multiple views and having a standard protocol for how you do this will help to not only make it faster for you as you go through these, but have standardized protocols so you don't miss any views. Because there may be some views that are better than others. And so here's an example with an apical 4-chamber view, where you can see again, left atrium, left ventricle. This is inverted view, right atrium, right ventricle, and a lot of fluid around there. And again, here's your descending aorta. So a lot of fluid around in here and triaging faster. And finally, thinking about suspected hypovolemia. So hypovolemia honestly can be a pretty challenging one to be able to look at in our patient population. And some of that is because it tends to be if our patients are pretty decompensating. Many times these patients are on positive pressure ventilation, and increase in RV afterload can affect how your IVC looks and affect your compression. And so we may or may not see a variation in your IVC. What you're looking at is to see, do you have a variation in IVC diameter? And so in certain situations, if you have an increased RV afterload, that may be patients with pulmonary hypertension, maybe patients on positive pressure ventilation, you may not see much of a change in your IVC. If you do, then it may be indicative that you have volume, a need for volume. And you can look both at the subcostal IVC view and other views as well to see, do you have changes as you give more volume? Again, hypovolemia can be a bit more challenging to assess in this patient population. So those are some of the indications to be able to use for cardiac point-of-care ultrasound in the neonates. And one of the protocols that's out is a SAFE protocol to be able, if you have an emergency, what are the views that you can obtain to rapidly assess a pathology that you can intervene on? So in this population, you have an emergency ultrasound, you put the probe on. Do you see myocardial dysfunction? If you do, get an echocardiogram. Do you see, do you see tamponade? Then yes, you can needle aspirate. If not, go to the lung. And what's important to recognize here, especially for those patients who have not had congenital heart disease or previous echo before to rule out congenital heart disease, is that a couple of different areas in this algorithm talks about if you have abnormalities, getting expert opinion needed to rule out congenital heart disease. So if you have myocardial dysfunction, you need to rule out congenital heart disease. Is it possibly you have an outflow tract obstruction somewhere? Do you have a coarctation? So there are a couple different spaces where you want to be able to rule out congenital heart disease. But having this kind of a protocol where you can have people, have your providers trained up so they can put a probe on and be able to intervene and triage and intervene. This was an article out from Dino de Rios down in Mexico that discussed a population of a couple years patients where they performed SAFE protocol in decompensating patients and found 12 patients that were decompensating with a median age of 37 weeks. So these range from 27 to 40 weeks. And the SAFE protocol was performed by expert physicians in 5, supervising neonatal fellows in 5, and neonatology fellows only in 2 of these cases. What they found was in 7 cases there were pneumothorax. They found 2 pleural effusions, 1 tamponade, and 1 where they assisted resuscitation. And they did 10 procedures that were performed, including thoracentesis and pericardicentesis, and found it had 100% survival and 70% survival to discharge. The x-rays took about 20 to 91 minutes following the event, so again, much more rapid. But remember, it is not a replacement for comprehensive echo. And there is certainly a risk for congenital heart disease in neonates. Pediatric patients do have proof of life. We don't necessarily from a neonatal standpoint. So there could be many different etiologies for that heart is not working as well. And making sure we understand that and recognize that as a limitation from doing cardiac POCUS is certainly important. And so are we doing cardiac POCUS? We are. In the US, this was a very recent publication out from 2024, discussing the neonatal cardiac POCUS, a survey of academic neonatal centers in the US. What I found really striking with this, if you recall a few years ago, 2016 and 2017, when there's a survey put out, the access to POCUS from a NICU was fairly limited. Here, the access to POCUS was actually 83% of the respondees had access to POCUS. 48 did use POCUS for cardiac indications on a regular basis. However, only about 16% had standardized imaging protocols. Most common use was central line imaging, and 9 programs had formal cardiac POCUS training, and only 4 had a formalized process with ongoing competency. So still a lot of work to do on considerations for if you are going to do cardiac POCUS, who's going to teach it? How do we work through this? How do we involve cardiology as well? With the ACE guidelines that are out and with recognizing that we want to be able to do this in a safe manner. And so having multidisciplinary training opportunities, this is actually a boot camp that we run here that has our PEDS ED docs help us with this, our cardiac ICU docs help us with this, and our PEDS ID doc has made some pericardicentesis models. We practice on this. We do some protocols looking at subcostal views during code situations and try to teach that as well. And there are guidelines out for through ACE on how to recommend the Echo Lab can participate in cardiac point of care ultrasound and training. And so there are guidelines available that you can work with cardiologists, say, here's what we'd like to be able to do. How can we get some help on trying to train up and kind of views and go for protocols? There's work and there's considerations that from the ACE, from one of the pediatric papers from ACE talking about strategies for competency assessment. That's a whole nother talk that we can go over another time, but thinking about logs, written examinations, libraries, clinical examinations, many different pathways and strategies for assessing competency. And the guidelines out from the American Society of Echocardiography, the TNE and cardiac POCUS guidelines from this past year, did give some guidance on minimum number of scans for cardiac POCUS, thinking about 25 with a minimum of 75 with a minimum of 25 for lung and heart function evaluation for initial competency, and then ongoing 50 studies per year for ongoing competency. Our communities are currently working through the National POCUS Collaborative, thinking about basic and advanced applications, and also for help with credentialing. So with more information and guidance coming out soon with that as well. It is important, of course, to do a quality assurance mechanism with regular image and case review. That is also helpful to involve our multidisciplinary colleagues with this, including cardiology. And then regular review from trainees, studies, and reports, continued educational opportunities, including for simulation. And there's some great models for simulators out there, cardiac simulators out there as well. And engaging a multidisciplinary review for cardiac POCUS with including, again, pediatric cardiologists. And if you're interested in more, I believe we shared this last time, but the American Society of Echocardiography has a couple of groups within that are ICU-based. There's critical care echocardiography, and also neonatal hemodynamics, SIG, for those who are interested in further assessment and evaluation and understanding what we can do by ultrasound at the bedside, and working with our cardiology colleagues on that. In conclusion, just wanted to say that cardiac POCUS is a very important tool, and I feel very strongly that if you have a coding patient, having more information and the understanding to know what to do with that information, recognizing the pathology so you can triage these patients faster is important, and we should be able to do all this. And there are many updated cardiac POCUS guidelines from ACE that outline the indications and programmatic structure, including the need for QA. We need a multidisciplinary team approach, and there are various uses that we can have for cardiac POCUS. There is certainly, and I know I keep saying this, but a risk of congenital heart disease in neonates, and something important for us to consider when we do see pathology. And I wanted to show, let's see if I can play these here. Yes, so this is actually, so we have a POCUS group here, and we have share some imaging or ask questions to each other. And in this evaluation, we had one of my colleagues was doing just an educational check for a UVC, and you can see the X-ray was here. It's not to be rotated a bit, but the read was that the UVC was in the correct location. And so we're looking at, there's this echogenic area within the liver that it almost looks like the UVC is going into that, but the X-ray seemed like it was okay. And we actually ended up getting a formal radiology evaluation, and it was infusing into the liver, and so it was not actually in the correct location. This was by an educational ultrasound. So there certainly is utility in us being able to utilize ultrasound at the bedside, and the more that we can have support for being able to train and to obtain the views as well as interpret the views, the more we can potentially add for our patient care. So with that, I will end and leave some time for a lot of Q and answer. Thank you very much.
Well, thank you, Shazia. That really was a wonderful talk, and it really is amazing to see how far POCUS has come in, even the last 10 years or so. So thank you very much. All right. So we will now move on to our Q&A panel discussion. Again, if you have any questions you'd like to ask our panel, please put them into our Q&A and I will relay them to our panelists. And joining Dr. Bhombal today, we have Drs. Gowda, Michelfelder, and Singh. Dr. Sharda Gowda is a neonatologist at Texas Children's Hospital. She is an associate professor at Baylor College of Medicine, and she's the co-chair, for the POCUS focus group, say that 3 times fast, for the Children's Hospital's Neonatal Consortium. And she has expertise in pulmonary hypertension, congenital heart disease, and pediatric critical care. Dr. Rick Michelfelder is a professor of pediatrics at Emory University School of Medicine, and he is the director of the fetal cardiology program at Children's Healthcare of Atlanta. And finally on our panel is Dr. Yogan Singh. He is a neonatologist and professor at UC Davis. He is currently chair of the European Society of Pediatric and Neonatal Intensive Care POCUS Working Group, and he also serves as the chair of the ESPNIC Cardiovascular Dynamics section. So thank you everyone for taking the time to speak with us today.
Thank you so much, Michael, for the introduction. Thank you so much for having us here. We are pleased to be here.
Thank you. So let's go into some of our questions. So for those, on our panel, in your centers, do you use POCUS during UVC insertion? If you do you have a portable probe or do you bring the entire machine to the delivery room? And has it increased success rate? I'm assuming that this attendee does UVC insertions, in the delivery room.
So we were using them for when I was previously at Stanford. Here we just got our ultrasound machines in our delivery hospital, so we're going to be start implementing that there. We did have better success when we utilized ultrasound for it. We weren't doing it necessarily in the DR, so we wouldn't have to bring the probes over in the DR. When I started doing ultrasound, I used the phase array probe, so the cardiac probe. I will say that from a learning and teaching standpoint, I know many others use the linear probe for putting in lines, and Ben Koziak in his talks about linear probe in there, which I think is actually a great probe to be able to use. But I don't know that I'm curious if anybody's using it in the delivery room. I have not heard of using them for lines in the delivery room, knowing that usually for those, we're getting them pretty quickly in and out. We have brought a ultrasound delivery room for other potential fluid management issues. So for hydrops babies, we've done that and we've utilized some of our smaller machines, and not necessarily handheld, but we did have a smaller machine we were able to bring there and position within the delivery room for that.
Okay.
Similar kind of approach, really, Michael, we do here as well. So I moved to UC Davis a few months back. So we are, again, building the team and training program. So we are training all our providers into the basic cardiac focus. And part of them is the line placement, more on the line positions. So it can be like, as we know, it can be static or can be dynamic. So static, we are putting the line how we normally do, and they check the position afterwards. And dynamic will be where we're doing the UVC placement under the ultrasound guidance. So I think it's a building the skills, a continuum of developing skills. So in the beginning, we are training the staff in the normal way we put the UVCs, like lines, and then check with the positions. Gradually, as they become more competent, there'll be next step towards that one as well. As Shazia said, we don't use in the DU. Most of our lines are done almost certainly in the ICU. So we do not use the line placement in the DU. Babies who have got the extended resuscitation, definitely we used in the past for the fluid management, for the pericardial effusion or the tamponade, those kind, but those are not day to day. Those are where babies not responding to the normal NRP protocols. And lastly, what you question did ask about the handheld or the smaller machines. As we know, traditional echo machines they're great, but they're bigger, they're powerful, but they have to be powered on. That take a few minutes, and also mobility takes little time as well, although they're getting smaller as well. But what we use is a more battery powered, always machine is on. So that saves some time for the emergencies, but we do not use the handheld. Most of the handheld at the moment, what we do have is a lower frequency probes, especially for the cardiac. So we still are using the our portable ultra focus machines, which can be any, like I'm not advocating any particular brand here.
Yeah,
Okay.
similar approach at Texas Children's as well. We don't do dynamic UVC insertions, and so I can't really answer whether the successful insertion has actually increased or not, but we know for sure, at least in the cardiac ICU, we take out malpositioned lines a lot faster so that there is no infusion of all these caustic medications directly infusing into the liver. I think for that extent, that has been useful for us. We don't really have, we're building our program as well here, like many other programs. So maybe one day we'll be able to bring it to the delivery room and then work on it. We'll maybe have the answer by that time. Thanks.
Yeah, I don't start UVs anymore. It's been a very long time. So you wouldn't want me starting UV with or without an ultrasound machine. But I will offer that in terms of systems, the laptop size ultrasound systems, I think are a reasonable for programs that are building a POCUS program are reasonable to consider. It's the lower price point, but more functionality than some of the handheld units. And we use one for our codes in the CI, for example, because it sits on the wall and unplugs, and then the battery's charged and it's got a good long battery. So something to think about.
Okay. Thanks, everybody. As a sort of, corollary to that question, there was a question from a participant. Would you recommend, well, is it possible to start implementing POCUS for UVC lines without having providers trained in cardiac POCUS?
Is that for me?
For everybody.
Yeah.
Yeah, for everybody.
I would say it is. Personally, I think I look at it as, the various areas are kind of modular, and I think in particular venous anatomy and line placement, I think could be modularized in my personal opinion. I think the other cardiac stuff requires a little bit more training probably.
I think, we started actually when we had some learners, we had quite a few of us that went to the POCUS course and then came back, and we're starting to try to figure out how we can implement POCUS. And we actually ended up looking at UVC lines 3 times a week. And that helped to get numbers up. It helped us to be able to assess and get more competence with that. We did have cardiology colleagues help us for some of the line positioning, but But we started off with looking at the lines. I think it's true that you don't have to have everyone trained up for it, but if you're going to start manipulating the lines, then you want to make sure that you have enough competency that you know what you're looking at before trying to pull back a line if you haven't really had as much experience yet. But the only way you're going to get experience is by doing it and by putting the probe on. And so having a method where you can assess lines, get used to it, allows for more people to get trained up to be able to move the program forward.
I agree with both Rick and Shazia. This one thing is really important here. With the kind of like with the simple basic POCUS, like what Shazia showed in the talk as well, looking on the just on the from the subcostal, looking the ductus venosus and then the IVC. That's a really easy way to teach. But as we know, any ultrasound imaging, if the ultrasound waves are perpendicular to any tissue, including line position, you see the tip very clearly. But if they're in parallel, you do not see at all. So danger and the limitations of the POCUS in this case will be if you use only one way, only one plane, if your tip and the distal part of the line you will see is not perpendicular, or especially if it's parallel to the ultrasound waves, you may not see tip. So 90% time it's not a problem. You see one way, you can see the position where the position is. But sometimes you do not see the position tip. So we recommend, and we do like that we should kind of flush like normal saline flush. You can see where the bubbles are coming from, where the flush is coming. Or as we progress, more people learn more cardiac POCUS and we get the more standard views. We can the two planes. Either you can the two planes, one are 90 degrees to each other. That's fantastic. In that case, those errors will be minimized as well. So lines looks very simple, but they're not that simple sometimes. At least in some cases, 10% when we see when the line has gone downwards.
Yeah, I think the competency or mastery of a procedure, especially cardiac POCUS, I think is a lot more involved than taking some imaging of the lines itself. So can being proficient in cardiac ultrasound definitely help and aid it much faster and much better so that the manipulation becomes much easier? I think that's a yes. But do we need to wait for that? I'm not so sure, especially because I'm more probably biased about folks who may have done 10, 12, 15 cardiac ultrasounds, then saying that to look for lines, then may feel confident that they can now do cardiac POCUS. So I kind of feel like maybe reserve the line, like have two separate entities as separate entities and then work on getting mastery in both.
Okay. Thank you. So one other question about, I guess, practice and competency. At your institutions, what criteria do you use for credentialing for cardiac POCUS? How many cardiac POCUS ultrasounds need to be completed and reviewed in order to be, for the practitioner to be considered competent to perform them independently? 25, some, authorities recommend more. What are your thoughts on that?
I'm going to leave this to the experts only because we are, as the Texas Children's Hospital POCUS Collaborative, we are coming up with those guidelines. More so, we are trying to borrow that from the PEM fellowship, which already has an established criteria. It's a conversation. It's not just a number, right? It's also the quality of the pictures and the quality of the images and the ability to identify what other person has captured as well. So there is a lot more nuances to that than the number itself. So I think that's where our struggle is, at least, because we're trying to come up with this for the whole hospital. So I'll actually, I'm here to learn from the experts here.
I can take, Michael, this one. I think this is a definitely, I agree with Shada. This is a continuous, it's a dialogue, but importantly, we need to help our programs and our trainees with the dialogue as well. With the TNE guidelines, which includes the POCUS, cardiac POCUS training, we said 75. That's the number if you look on the numbers, but it's a more competency based as well. Then we have to put the number. The cardiac POCUS is not, as compared to other systems, we know takes time. it takes more scanning, and definitely it's a 3D model, need to have more spatial orientation. So 3 elements are here. One obviously is getting the images. So imaging acquisition is very, I think, relatively more simpler. Second, the interpretation of the images, which is, again, not only detecting what you see, but also what you're missing as well. And third is implementing that knowledge and the skills into the practice really. So can you incorporate those in the clinical decision makings? So in many other systems, you can get away with the 25 scans, and we are as a part of the National POCUS Collaborative, we are coming with some guidance on these credentialing programs. So that's the space to watch out for until we agree on a certain numbers. We'll give some numbers for the cardiac POCUS as well, but I think that's our TNE guidelines where we agreed like on the cardiac POCUS too. Coming to our own institution program, we follow exactly what we preach really. So what we had done here, like in my institution, one is the broadly very basic POCUS that includes many system POCUS. Then the cardiac POCUS, which is the more advanced POCUS. And then is the TNE, that's 3 tiers, what we had done, basic, advanced, and the TNE level. So I think that's where we can work. But we just not the numbers. We need to look on the people's skills on all the 3 areas: imaging acquisition, interpretation, and how they're using the information in the clinical context to make safe decisions as well.
Rick, I'd actually be kind of curious on your take on cardiac POCUS. I mean, through the ACE guidelines, the TNE guidelines, it had recommendation about 75, and with some of that including line and functional assessment. From a cardiac standpoint, obviously it's a lot more, but you're looking at congenital heart disease. When we're looking at kind of just looking at, for cardiac POCUS standpoint, line position, heart moving or not, I mean, we're working towards that, Emery, with having a multidisciplinary group that's working on credentialing. With the numbers, but I'm just curious your take and what your thoughts are.
I think for a structurally normal heart, I honestly think, I mean, I have not trained, I've not done formal POCUS training with neonatology fellows. I would think that 75 seems like a fair target. One of the things we use in our echo lab, or I've used in the past with both training sonographers and fellows, is competency checklists, which I think would also be a very important component. So, of those 75, if you do 50 echoes with the depth set way too deep and you've got this tiny little heart at the top of the sector, and all that, I think technical competencies and interpretive competencies obviously would be a good thing to also incorporate. But I think 75 sounds fair, as long as it's, maybe you have basically 4 areas. I mean, if it's roughly 25 per area, I think. But I also think maintenance of competency guidelines are important too. So you do your fellowship and then you go somewhere and you do it twice a year, your skills are going to wither quickly. So I think maintenance of competence is actually really important as well.
Okay.
Process considering the checklist of making sure that they have all of this adequately done, because you can do 50 and still not quite do it, or you can have 10 and do it pretty well. So.
Okay. So this is a question for Rick. For programs that are just getting into cardiac POCUS, there is occasionally some pushback from cardiology. What are your thoughts on the best way to approach the cardiology department regarding cardiac POCUS and assisting with that?
It can be tricky. I was definitely a strong detractor probably 5 to 10 years ago. I just thought it was, and I was frankly being territorial unnecessarily. I just, I thought, why did I do all this fellowship, blah, 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 and I actually think for all the points that really Shazia pointed out is that I also know our system now, which is, you call the cardiology fellow's down the ED with 7 cardiology consults. And now you're calling them for a really, really sick baby. And, I see POCUS as a benefit for all those really important reasons. I personally, I'm sitting here listening to these talks and comments. I don't know why we don't see more NICU fellows in our echo lab. I think, I have a question for the panel, honestly, which would be, what is, because it would be very easy. I mean, our sonographers are really good here. Most of our fellows get a lot of their initial training from our sonographers. I mean, we have, many senior sonographers. I'm curious, what I'm wondering is what's the nature of the bandwidth? Because I feel the same way about maternal fetal medicine fellows, right? And they get like a 2-week rotation in their 3-year fellowship in fetal echo here. And I think it's a bandwidth problem. So I'm curious what you guys would feel about what is the bandwidth of neonatology fellows to be getting regular exposure like that? Because I
So
think
we've done that, Rick. There's been some fellows that have been really interested, some junior faculty that have been interested and have gone to the Echo Lab and try to carve out some time to do that. So I think it just depends on whether we build it in from a fellowship standpoint as elective or build it in as just an exposure as expectation in there. I think we're early on enough that starting off the elective and I was going to say, just wait, there are some coming I'm going to be asking about. But there are junior faculty that are interested in coming in, and I think trying to time it with you all. There's a ability, I think part of the question is how long do we think they need to spend within the Echo Lab and with the sonographers to make to get enough exposure and experience that is certainly worthwhile. And I think, whether it's a couple weeks, whether it's longer than that, there may be some consideration for bandwidth to fit within their fellowship. But if we can do it over a longer period of time, they're in a fellowship for 3 years. If we can do it for a longer period of time, maybe we can get some more exposure within that.
I think ultrasound skill, a cardiac focus skill, just like any other thing, has a higher attrition rate if they don't keep using that. So I encourage the fellows to try and continue to hold the probe and do what they always are interested in. And you can see the interest is certain folks are really, really interested, and certain folks are like, okay, I know enough to know that this might not be my forte. So, and that's okay too. We need to respect that as well. As long as the folks who are wanting to do it will continue to use that skill and continue to help the clinical management. I think that's probably what we need to encourage. It's not just the bandwidth of the neonatology fellows itself, it's also the echo faculty, the echocardiographer that needs to hang out with this fellow, because I think it's going to be a little different experience for them as well, from neonatology perspective to the cardiology perspective. Cardiology fellows are expected to learn certain things and know certain things before they even go to the echo, handle the echo machine, and that's not what it is for neo fellows. So I think managing expectations and also managing the bandwidth for both parties is really important here, and then the time at Echo Lab as well.
Okay. So a question for all of our panelists. Do your cardiology colleagues assist with teaching cardiac POCUS at your institutions? And are your cardiology colleagues also involved with quality assurance or overreading POCUS studies? Like, does every POCUS study targeting the heart get automatically reviewed by one of the cardiologists, or is it only as needed?
At this point now, we're not having them review all of them. They are involved in our training. We have a 2-day boot camp, and cardiology is involved with that. And we also ask them for some lecture and hands-on support throughout the year as well. We have a fellowship curriculum that includes cardiac POCUS. So we do ask for help with that as well, but we don't necessarily have them at this point now overreading. I think that's something that we've integrated within the PAC system. And Rick, I think that's sort of new information, but we've integrated within the PAC system for all of our POCUS studies. That is something that's accessible and able to be able to do that, but we haven't necessarily done that just yet.
Similar kind of approach, really. I don't think we do really need the cardiologists to look on all the POCUS studies when we are not sure, or like, obviously people who are in the training, they should not make decisions, they should acquire the images. Who are trained POCUS expert can review those images, and if there's any doubt on that one, you need a second opinion. Definitely close collaboration with the cardiologist is the key there, because any intervention you make based on the POCUS image, those ones should have formal echo done. Similarly, if you're not sure what you're dealing with, or something like doing like echocardiography, I've done full structural echo for many years. We always find those cases where cannot be 100% sure. So we had no hesitation. In fact, we keep a very low threshold to discuss with our colleagues. So I think it's just managing their workload as well. I think if we, as a program, in any situation, will ask our cardiology colleagues to look on all the cardiac focus, it may be a little overwhelming and very, very little rewarding for them. But I'm sure they will support us when we need really them, so that we can use their expertise when they can make the difference.
But I do think that if you're starting a program, you probably do need to have some guidance with other disciplines, like with cardiology, be able to help, especially as you're starting off and don't know you have much exposure yet to that.
Completely. I think in the beginning, the close collaboration is the key. Discuss with them how much resources they can have in terms of the supporting the training, lectures only, hands only, echo lab. If they got the bandwidth to support more, that's fantastic. That's great to have this expertise. But equally, if they say we don't have that one, we can, in that case, talking to them, okay, fine, we are doing this, so that aware what we are doing and what help when we need the help, they are there. So I completely agree. They should be in college. They should be part of the training development program and also discuss with them what we are doing. So it's a close collaboration is the key for the success.
When we started off, we had both cardiology and radiology that helped us with QA. So, and PICU, actually, PICU, we integrated them as well.
Okay. So another question for the panel. Do you have a specific protocol for which views to obtain and in what order? Shazia, you touched on that in your talk, but do any of the other panel members have another way of approaching it, a standardized way?
Um, And as we know, for the echocardiography, we had to follow certain protocols. Standardized views are the really key. For the cardiac focus, it really depends why you're doing it. Depends on the indication. So we, like as Shazia said during the talk, 4 or 5 indications. If you're looking for the lines, totally different indication. Similarly, baby suddenly collapsed, really looking for the tamponade, looking for the pneumothorax. This all depends what you're looking for. So key question is for the cardiac focus, what is my question is, which cardiac focus can help in answering. So we do not use a standard protocol for the emergency situations. But if you're using a focus more for the evaluation, then yes, we definitely recommend in a way. But there's no hard and fast rule. Most people find like subcostal wave for the pericardial effusion very easy, but equally perhaps long axis we going to the short and go the apical and subcostal. So it really depends on the what's my clinical question is and how the baby is. The baby's tummy is distended and you don't want to stay away from the subcostal abdomen, or whether baby is very settled, you can do more subcostally. So I think that will come with the training and experience. I think we rather than sticking to a standardized protocol for the cardiac focus as compared to echo.
I would offer that I think having I'm a big fan of protocols. I think having an approach where you generate the same images in the same way every time actually helps learners pattern recognize. So I think if I think you're talking about yoga and you're talking about the same thing. Which view do you use? But I think as opposed to just kind of put it somewhere on the abdomen and look up, I think having a set window and axis that you align in over and over again is helpful for comparing one study to the next in your brain as well as clinically.
I completely agree, Rick. I think typically when you're doing the training and the patient is stable, not an emergency, we definitely go with the person long axis view, short axis view, apical, subcostal. That become their second nature really. So that when they're doing, so we are looking those images systematically same like pattern recognition. And also they do not miss things, especially they're not doing very often as well. So I think completely agree. Protocol really helpful that way. So every member who is doing the because there'll be so many providers. It's not only 1 or 2 people. All are requiring similar kind of imaging acquisition. It's easier for us to review as well afterwards.
All right. Well, I wish we had another hour to discuss this, but unfortunately our time is at a close. So thank you to all of our panelists. Thank you especially to Shazia Bhombal for giving us such a wonderful talk today. Just a few more housekeeping things to end with. In the chat, you will see a link to the NeoPocusCollab website where you can find the recording of this webinar along with all of our other prior webinars. So that's really a wonderful resource. And just shout out for next month. Please join us again on March 25th for the third webinar in this Cardiac POCUS series, where we'll have Dr. Gabriel Altit will be discussing shock in the newborn. So thank you, everyone. Again, thank you to our panelists and our speaker, and hope you have a good rest of your evening.
You.
Thank you.
Thank you so much, all. Thanks for the help. It was great.
Yeah, nice meeting you guys.
Thanks.
Likewise.
Likewise. Thank you.